All right. Well, I know some people will still be filtering in here, but welcome to the Oregon Bioethics and Humanities Colloquium presentation, Structures of Justice and Fairness in Complex Disposition by Dr. Gina Campelia. I'm Aaron Klein. I'm an associate professor here in the Department of Neurology at OHSU. Today, I'm really excited to be introducing and moderating Dr. Campelia's talk, as Dr. Tate, who usually runs the OBHC, is out of the country speaking at a conference. So I'm hopeful that he'll be able to join virtually if possible. I just want to kind of remind everybody to please mute yourselves. That would be great. Um, and I want to remind everyone that today's talk is part of the 2023-2024 Oregon Bioethics and Humanities Colloquium, or OBHC, which is an endowed speaker series that tackles complex issues and critical questions in bioethics and the medical humanities. And today, it's my pleasure to introduce our speaker, Dr. Gina Campelia. Dr. Campelia is an associate professor in the Department of Bioethics and Humanities at the University of Washington School of Medicine and a consultant for the University of Washington Medicine Ethics Consultation Service. Her recent scholarship concentrates on critical theory and oppression in healthcare, relationality, empathy, epistemology, and feminist ethics. Dr. Campelia's research generally attends to care ethics, feminist ethics, and virtue ethics in the clinical setting, with a special focus on the intersection between clinical ethics and axes of oppression. At the intersection of virtue ethics and care ethics, her writing and practice focuses on establishing structures to enable and encourage empathy and facilitating greater recognition of the relational constitution of patient identity and decisional processes. By way of background, Dr. Campelia joined University of Washington as an assistant professor in October 2016. She received her PhD in philosophy at the Graduate Center at CUNY under the supervision of Virginia Held. So please welcome please join me in welcoming Dr. Campelia.
Thanks so much. Hi, everybody. I'm going to share my slides in a second. I'm really, really happy to be here. I know it's early on a Friday, and I'm hoping for this to be more discussion and less lecture, in part because what I'll be presenting today is something that I've presented in different formats before, but I'm also working on what I hope ends up being a very practical essay on how to um, respond to, think about, deal with these, I think, increasing complexities in discharge from inpatient settings. As far as I can tell, it seems like there are increasing complexities around it. So, just with a little bit, Aaron so nicely gave some background about me. What I'll say is that I'm a visitor on the unceded lands of the Duwamish, the coastal and all coastal Salish people, and that's where I live, work, and play. And I really want to honor the peoples who take care of these lands. And I try to do that in my work as a clinical ethicist, and it's part of why I focus on justice and thinking about power and privilege and oppression. Another reason I focus on those things is because I was a trained philosopher. So while I spend most of my time either in the hospital or with medical students now, um, I'm a philosopher by training and spent most of that time working in critical theory and epistemology, critical race theory, feminist theory, care ethics, and so that's the work that is sometimes not centered in bioethics, and so I'm trying to bring it together with all the things, all the standards we've had for years in bioethics, not just years, but centuries if you think about ethics in medicine more broadly. So with that as a starting point, let me share my slides. And I always like my talks to be really interactive, in part because I have this limited experience as a limited knowledge as a philosopher and limited lived experience. And so I really want to make sure that we can all talk together about these really complicated issues. So what I'm going to do is start with a case and ask for some reflections on it. So Ben Lewis is a 58-year-old and who is the patient who was admitted for heart failure exacerbation in the setting of experiencing homelessness for over 10 years and many barriers to accessing outpatient care. Ben has ischemic cardiomyopathy with an ejection fraction of 36%, no revascularization targets, hypertension, history of smoking and IV drug use, primarily heroin, and a history of non-adherence to medical therapy. After 4 days of an intravenous diuretic and more reliable and / modified diet from what his baseline is outside the hospital, he's medically stable and ready for discharge. Ben's daughter, who's his DPOA, and healthcare providers agree that a skilled nursing facility would be the safest disposition to promote further stability prior to returning to where he lives in his tent. However, social work has not been able to find an accepting skilled nursing facility. Ben is a white cis male who worked for a local drywall company for most of his life. He hasn't worked for a decade due to on-the-job back injury. Ben tells clinicians that while he has been in recovery for years, he had developed an opioid addiction after his injury. He was out of work and with no other options, forced into chronic homelessness. Per psychiatry, Ben likely has some PTSD from a history of surviving attacks while living on the street and in shelters, which has led to some defensiveness and aggressive behaviors, such as verbally threatening staff and at one point striking a security guard on a previous admission. Without an accepting skilled nursing facility, healthcare professionals worry that Ben will decompensate quickly if he returns to his tent, whereas geographic location and barriers to transportation make it unlikely that he will be able to adhere to his medical therapies and diet. There's also winter, and he's at higher risk given the cold conditions. So I wanted to pause for initial thoughts, and I don't know if I can see the chat, but would you say, and please just unmute yourselves, is discharging Mr. Lewis here where the only option is his tent in his best interest? Any thoughts? And maybe Aaron and Dave, if they're, oh yeah, here, oh, now I see the chat. Okay,
I can moderate the chat, Gina.
thanks. Certainly not in his best interests. Other thoughts? What does the patient want? Good question. Yeah, does he have decision-making capacity? Good. Yeah, so good. So a lot of focus on his decisional capacity and what his preferences are. So I think in disposition, there's this conjunction of what's in a patient's preferences and also what is in their best interest or benefit, both from the patient's perspective and from oh, good to see you, Prasanna. Yeah, so we tend to focus on best interests, I think, when we're talking about hospital discharge, especially when we get to the point of an ethics consult is being called because of complex disposition. Because in some ways, I think what we end up falling back on is this a safe disposition? And that's what we mean by is discharge in Mr. Lewis's best interest, because there's a sense in which, you know, especially if Mr. Lewis does not want to return to his tent or feels it's unsafe to return to his tent, it's absolutely not in his best interest. But if we get to a place where there are no other options, this question might change, or if he wants to go and has decision-making capacity, this thinking about what's in his best interest changes. not just because of respect for autonomy, but because we're thinking about what's in his best interest, not just in a global sense for any patient in similar circumstances, but from his perspective, what does it mean for something to be in his best interest or not in his best interest? And that helps us answer the ethically justifiable question. It's not ethically justifiable without asking these further questions about understanding what Mr. Lewis's preferences are, what best interests, safety, benefit, et cetera, look like from his perspective. And so that kind of tells us what the next steps are that we would take, as many of you are saying. I saw there might be a couple other chats, Dave or Aaron. Anything?
Yeah, so I mean, are those the only two options, right?
Good. Good. Yeah. Yeah. So, and possibly getting creative about might there be other options, just because these are the standard options we would go to in this kind of case. Maybe there's another option to consider that we should work through with Mr. Lewis, especially bringing his goals and preferences to the center. All right. So this case evolves. Mr. Lewis is medically ready and a skilled nursing facility is accepting. Mr. Lewis and his legal next of kin are declining the skilled nursing facility due to proximity to family and past bad experiences with and discrimination by staff at this facility, as well as freedom restrictions and food at the available skilled nursing facility. So Mr. Lewis would want to leave and come back. He often expressed being worried about checking on his tent to make sure that it was still there and that his things were secure. Mr. Lewis recognizes that his tent is not yet medically safe, and asks to stay longer at the hospital, hoping to find another disposition, as some of you mentioned, another option before returning to his tent eventually. His daughter is advocating for a longer hospital stay, too, out of concern for her father's safety and her ability to check up on him. So here, I think this gets a little bit more complicated. Is discharge to this skilled nursing facility, leaving aside some of the practical concerns I know we have when a patient's declining the particular discharge, is it in Mr. Lewis's best interest? The skilled nursing facility that I'll go back. He doesn't think so. Good, Laurie. Other thoughts? Is there any sense in which it's in his best interest? Maybe from a medical perspective. Good, and this is where some of the practical considerations come in. So, yeah, so I think this is where things get really complicated. And so from a practical perspective, there's an elephant in the room. I can't read the rest of that comment. What was it?
The hospital's interest. A generation ago, discharged this early would otherwise have seemed compelling.
Good, thanks. Yeah, so there are a couple of practical considerations here that intersect with thinking about the ethical justification of disposition in this kind of narrative. So if most skilled nursing facilities will not accept a patient who is declining to go. So you can't, in a practical sense, force a patient to go, even if it was argued that that was in the patient's best interest, which I think there's a lot of questions around that. But so there are some practical considerations there. And then there's also these justice questions, the distributive justice questions that cover a whole lot of ground that we'll get to in a minute. In terms of thinking about whether this kind of disposition is in Mr. Lewis's best interest, I think there's a sense in which you can say, well, we see the way in which it's in his best interest medically, insofar as a prolonged hospital stay is not necessarily safer than going to a skilled nursing facility. and a skilled nursing facility is all agree in this case is safer than the tent. It's just that from Mr. Lewis's perspective, this particular skilled nursing facility was unsafe from other dimensions of not just safety in general, but medical safety. If you think about social determinants of health and how disparities in care are often constituted by things like discrimination in a healthcare institution setting. And so if we think about it in that sense, which is how we, if we think about the social nature of medicine, they really intersect, and there are ways to argue that it's and as soon as we take Mr. Lewis's perspective into account, we see that it's not purely medically safe to discharge to a skilled nursing facility. In fact, while there might be safe features about it, there are also unsafe features about it, all within a medical perspective. At least thinking holistically about a medical perspective and not purely clinically. And so that complicates, is it ethically justifiable to discharge Mr. Lewis? Again, setting aside the practicalities of a skilled nursing facility wouldn't accept him if he's declining anyways. Overriding his preferences, when those preferences are grounded in a view that this is not medically safe, that changes both how we think about respect for autonomy, which is, we're always obligated to respect the preferences of the patient insofar as we're able to. But then on top of that, we have a shift in how we're thinking about best interest and medical safety. So even we can't justify overriding his preferences when it also is arguably an unsafe environment. So this is where we start to see how justice and various dimensions of justice come into this. And that's really where I want to focus some of this talk, is thinking about not just how justice intersects in these cases in a distributive justice sense, as we'll talk about here, but also how does it impinge on all the other ethical obligations and frameworks that we typically use in ethics consultation. So in this case, as a lot of you raised, from a clinician or a hospital perspective, we're very much concerned with not causing the patient harm, as well as promoting their benefit. That's why even we will strive for a medically optimal discharge, but when we can't have it, we'll strive for a sufficiently medically safe discharge. We'll work to protect a therapeutic alliance so that even if the patient leaves to a disposition that that nobody feels, that both the patient and clinicians don't feel great about, that there are ways in which you're trying to protect that relationship with the patient so that they, for instance, don't avoid medical care going forward. We're thinking about respect for autonomy, as many of you mentioned, and here we're differentiating between non-autonomous versus autonomous preferences, so preferences that come from a place of having decision-making capacity versus not. We might also distinguish between wishes and choices, so a patient may wish a certain option for disposition is available, but maybe it's not an option despite all efforts, and therefore it's not really a choice that's available. That might be incredibly unfair that that's the case, and that's where justice can intersect, but it simply may also just be the case that that's not a choice that's available. And then also along these lines, respecting the patient's view of safety as part of determining medical safety. And then also thinking about self-determination and bodily agency. So this patient, one of the major concerns is his lack of freedom in certain settings. And so that's at the forefront of his attention. And then stewardship, right, which we use the word stewardship in clinical spaces, but what we're really talking about is a particular kind of distributive justice, but that's not the only kind of distributive justice. So there's in a broader way, we can talk about the unjust distribution of societal resources to meet health needs. And so that's not just an inpatient problem. It's happening outside the hospital, and it can create distinct problems for those of us working in acute care because there aren't the societal supports outside the hospital to meet needs that patients have. And so that's, I think, when we're stewarding resources within the hospital, that's one dimension of this, right? We're trying to preserve access to acute care according to need. That's the job of a hospital. But at the same time, we're facing this unjust distribution of societal resources to meet health needs that is so extreme that it's making disposition unsafe for patients to the extent that they may remain in the hospital for a prolonged period of time, even though they no longer have acute need. And of course, cost and reimbursement goes into this as well, and is a factor insofar as without thinking about that, we can't in a prolonged way preserve access to acute care. And then from the patient and family perspective, honestly, they're thinking about many of the same things, just potentially in a different way. So we see in Mr. Lewis's case, he's very concerned, and his daughter's very concerned about his safety, both in a medical but a holistic, social, biopsychosocial sense of the term. Um, they're worried about his best care and well-being. He wants to have choice and control on in his care and what he recognizes as a really limited way because of the circumstances he's operating within. Self-determination and bodily agency. I separate these from respect for choices because we'll get into this in a bit further, but you can see how choices, if we think about his choice about discharge, whether he goes to a skilled nursing facility, there's another option available, or he goes to his tent, but also his ability to have freedom of movement and control over his body will factor into his decision making as well. So for instance, he may opt to, if we're left with these two options as the only options, the skilled nursing facility and the tent, he may opt for his tent because of this value of bodily agency and self-determination, as well as the value of avoiding an unsafe experience in the skilled nursing facility. And that goes hand in hand with reducing restrictions from being in the hospital. And also he's centering familial and caring relationships, so proximity to family. This also goes hand in hand with medical safety, right? If he feels unsafe in the skilled nursing facility or disempowered and unable to advocate for himself, it'll be even more important that his daughter is nearby so that she can check up on him and help advocate for his needs. And justice and fairness too, it comes into play in these cases, as many of you know, that Mr. Lewis recognizes the unfairness of his situation, just like his clinicians do. It is not fair that he does not have housing, that there aren't those social supports that would enable him a safe discharge that also honors and respects his bodily agency and self-determination. Okay. So what I want to focus on is how do we bring these dimensions of justice into here? So I think perspective is important, both in the sense of understanding what Mr. Lewis's perspective is, as well as everybody else's who are engaged in the discharge planning, but also layering in thinking about power. So um, I have mixed feelings about this chart, which I won't get into, but I think that it helps us to understand the way I think about it is societally, not on an individual, right? Whether you are strong and powerful or not, but societally, how power is attributed and understood in our social norms fit with the way this wheel is defined, right? Or portrayed. So marginalized identities and communities are marginalized by society because of an understanding of where power should be attributed and where it is when people are empowered rather than disempowered by our social structures as well as our interpersonal relationships. And so when we bring this into thinking about justice in this case, which I think of as, and I'll get to in a minute, as a grounding ethical principle or virtue that we should bring into all the other ethical obligations we're thinking about. What we want to do first is understand how people are powered or disempowered in the particular context. So, for instance, who has the power to define the safety of the environment? Does a similar question in Mr. Lewis's case would be, does Mr. Lewis's experience of discrimination does that contribute to the narrative of whether the skilled nursing facility is safe or unsafe in the chart, in the way people are talking about it, and so on? What is the dominant narrative? What is the counter narrative? Is the dominant narrative that Mr. Lewis is refusing a safe option? And if that's the case, how do we bring the counter narrative into the story, which is Mr. Lewis's narrative that it's not a safe option, and that's why he's declining it, as opposed to he's declining it because he doesn't like the food or something like that, which he's also stated, but that's not his primary reason. And then what policies and procedures need to be in place to treat like cases alike? So how do we make sure that not all patients are being treated exactly the same in this kind of case, but that we're treating like cases alike? So how do we factor in the inequities and disempowerment that in particular Mr. Lewis is facing related to wealth, housing, potentially ability? How do we factor that into the ethical analysis of what to do? Yeah, Colin, go ahead. Is there a raised hand? Yeah.
Thank you.
Yeah.
When cases similar to this come up, one of the questions that come to my mind is there a threshold for how much risk we will allow a patient and a family to take on, to the point that we'll go only so far as participating in a level of risk, but at some point we'll say, no, that's just way too risky. We can't participate in that decision or accept that decision.
Yeah, I think that's still true. And defining what that level is really hard and really case dependent. In some ways, it really depends on the clinical details and whether there's clinical consensus that this is so unsafe, or a standard of practice dictates that we would not do X for any patient, regardless of social identity and what risks they might be experiencing in terms of oppression. What I do think, what I would say about it is that I think thinking about power can shift the way we think about not necessarily the threshold itself, though I'd have to think more about that. I think it might shift the threshold, but what it can do is help us to think about the dual risks that a patient might be experiencing, who's both at risk potentially. So if Mr. Lewis, for instance, is both at risk of serious harm because of how he's particularly disempowered in society along the lines of wealth and housing stability and ability. So he's at risk for serious harm, and we have an obligation, healthcare professionals have an obligation to protect him from harms, and that's non-maleficence, right? Standard non-maleficence. But I think we take it particularly seriously when we know that Mr. Lewis is at heightened risk of harm because of these systems of oppression and how they operate, right? So he's more likely, he's at higher risk of morbidity and mortality because of those things. And so there's a stronger obligation to protect from those harms. At the same time, because of those systems of disempowerment, he's also at risk of not having his choices respected and being and losing power and control and self-determination and those sorts of things. So I think sometimes we have to hold those two things side by side, not just in a respect for autonomy versus non-maleficence. It is that in a sense, but also there's a heightened way in which I think considering overriding choice has more serious effects for folks and for communities who regularly experience disempowerment over their and overriding of their choices and self-determination and restrictions on freedom in society. So I think that sometimes we might have to weigh that a little more heavily and allow more risks on the protection from harm front. But it's very patient specific and kind of specific to the clinical details as well. I'll come back to that too. Any other questions about that piece? Thanks, Colin, for that question. So one thing I've been working on, and this is far from perfection, and some colleagues and I tried to put this together, is shifting from the standard for principles to just generally a broader sense and thinking about consequences, obligations and responsibilities, virtues and values, and relationships to incorporate this piece about justice where we're talking about power and privilege. So when we think about consequences, we're thinking about consequences like I just talked about. What are the consequences of not just protecting somebody from medical harm, but also potentially overriding their choices in the context in which they might be particularly marginalized and disempowered in our society. Likewise, obligations and responsibilities. Respectfulness might look a particular way when we think about power and privilege in our society. So for Mr. Lewis, for example, and I think this intersects with trauma-informed care, caring for Mr. Lewis, who has this prior experience of being attacked on the street and being at risk for harm and safety, be constantly at risk. I think, taking that trauma-informed care approach is part of the obligation, right? Announcing yourself when you walk into the room, explaining what you're doing as you're doing it, et cetera. Likewise, virtues and values, I won't go into in detail now. And then relationships. For Mr. Lewis, we're going to focus on, in many ways, the therapeutic alliance. So if we can't find a better discharge, which sometimes happens, unfortunately, because of how our society is set up, we may still be able to focus on that relationship with Mr. Lewis, identifying those forms of power and oppression that are affecting him, even just by asking open-ended questions like, how has your experience with healthcare been up until this point? I want to partner with you. How can I do that? What does that look like to you? Right? How do we build the relationship, not just an understanding of his preferences and goals? So this is my general framework that I'm building. Again, far from perfect. But then how does it apply in a complex disposition? I think the main principles or virtues that I'm thinking about are respectfulness and relational autonomy, non-maleficence in the biopsychosocial medical sense, bodily agency and self-determination, and distributive justice. And again, for justice, when I say distributive, I don't just mean stewardship of medical resources. I also am thinking about things like medical systems are not always optimally safe for all patients. considering disparities in care, stigmatization, and other forms of oppression. And so how we distribute different resources is informed by that. Like at the same time, hospitals can't be the only source of our societal public health care, and then responding to according to patient need will often require more time and resources. And I think that that is justified. I think sometimes we worry about justice as equality, treating every patient the same, but we want to come back to the treating like cases alike, and the more policies and procedures we have in place to help us understand that, the more we're going to be able to reduce bias while also equitably treating patients according to need. What that means in Mr. Lewis's case is that it's ethically justifiable to allow more time, even though I think, you know, in a case like this, I'll hear you have this argument that comes forward that's, we have a skilled nursing facility. He no longer needs acute care. He should go to the skilled nursing facility. That's how we would treat any patient. But there's a legitimate argument here that that's unsafe, because it's a discriminatory environment for Mr. Lewis. He's likely to, even if he is sent there, he will leave and go to his tent, which everybody agrees is not safe at this time. And so I think allowing more time to try to find another option is justifiable using these principles. Not endless, right? But finding more time, and really making sure that we're transparent with Mr. Lewis along the lines of justice and respectfulness about what the barriers are to disposition. And I think that that's where a lot of your comments about how do we get creative here come into play, because if we're transparent with Mr. Lewis about what exactly the barriers are, for example, in his case, the barriers are largely around these documented instances of him acting aggressively to staff, and so skilled nursing facilities are not accepting him because of that. And so we might talk with Mr. Lewis and exactly about that, be transparent about that, and plan with him, how do we change this narrative together in the chart, right? How do we make it the case and then reapply to skilled nursing facilities with a new narrative reestablished? And that's both about changing a narrative that might be unfairly characterizing what's been happening with Mr. Lewis along the way, as well as working with him on, if there are ongoing instances in which he feels threatened and responds in a certain way, how can we change that dynamic and work with him to do that in order to get him to the place he wants? And then if he's medically stable and safe, and a safe though not optimal disposition is found, then we want to minimize any foreseen medical social harms, right? So if this is the only option and he declines and wants to go to his tent, then we're going to work on finding all sorts of ways to make sure he has access to his medication and so on. Similarly, with discharge to a skilled nursing facility, can we work with that skilled nursing facility on his report of discrimination? What actually happened? Is there anything we can do to help address that? Or can we find a way for him to report and for there to be adequate response to his experiences of discrimination upon discharge or after the fact? I'm going to skip ahead, just looking at the time. So this gets into this part 3 of the narrative, is that we imagine he's not medically ready for discharge, but he wants to go to his tent. So this is what we might otherwise call an AMA discharge. And again, here we want to think about who has the power to define the narrative, what it means by an environment being safe. For instance, does Mr. Lewis feel unsafe in the hospital? And to him, his tent is safer. But the narrative we're telling is that he wants to discharge against a medical advice to an unsafe environment. So how do we actually articulate that narrative in a way that gives power to his story, and so far as he'll share it with us? And we want to think, and that helps us to think about inclusive terminology. So thinking about what actually is meant by safe discharge, like I just said, is medical readiness independent of what the discharge options are? Is he declining or is he refusing? One of the ways we can shift from, sometimes that language around refusal has that way of reinforcing this hierarchy of healthcare professionals are dictating in a paternalistic way what the options are, and patients are accepting or refusing. We can say declines, but also I would actually prefer, what is the patient choosing or preferring if it's, not an autonomous choice? And why are they choosing that? So rather than saying Mr. Lewis is refusing to stay in the hospital, which is the medically safer option, or declining even to stay in the hospital, which is the medically safer option, or declining medical therapies that are beneficial, moving towards, Mr. Lewis is expressing a preference to return to his tent because for him that is medically safer for X, Y, and Z reasons, or whatever the reasoning is, if that's the reasoning. And some people will talk about patient-directed discharge and that to capture that instead of an AMA discharge. And then thinking about terms like acceptable or unacceptable, again, we're thinking about socially, medically for whom. So in this kind of case, and I didn't read the piece, but we're thinking Mr. Lewis's decision-making capacity is unclear at this point because he won't engage in further conversation and just says he's ready to go and wants to go and he's taking care of himself and he knows how to take care of himself. So the recommendations here are the same kinds of principles I used above, but here we do ultimately have to respect his bodily freedom and his choice to go to his tent. We're not clear if he really has decision-making capacity. He perhaps does. It's difficult to assess. But so while we ultimately have to respect that, and we can't compel him to stay in the hospital, this depends a little bit on where you are practically, whether that's even an option legally. But here it is unlikely that we would compel him to stay, in part because of thinking about non-maleficence, or largely because of thinking about non-maleficence. So we might encourage Mr. Lewis to stay for a time. We might work on understanding why the hospital feels unsafe for Mr. Lewis, or why he otherwise wants to go or doesn't want to be in the hospital. Recognizing, validating him, whatever concerns he has about staying in the hospital. And then at the end of the day, finding whatever resources are possible, right? Asking him to stay for long enough so that we can meet whatever obligations we have to make sure it's as safe as possible of a discharge. We may not be able to compel him to stay while we get that sorted out, but that would be at least the minimal goal, is to encourage him to stay for those purposes. And I think this is the kind of case where thinking about for a patient who in so many ways has their choices limited and disempowered by society, respecting the choices, not just about respecting a preference that's coming from decision-making capacity, but also about respecting his self-determination and bodily freedom. when he may be limited, when that may be a really serious and primary concern for him because of limitations societally. And then established consensus regarding whether the benefits of compelling Mr. Lewis to stay in fact outweigh the harms. So that may change our calculus. But we have to be really specific about, will compelling the inpatient stay result in therapeutic interventions such that the benefits of those interventions will outweigh the harms, or will he not accept those interventions and we can't compel those interventions, so why are we compelling him to stay, for example? And then what is required to compel Mr. Lewis to stay in the hospital? And then thinking about those specific harms and whether or not they might outweigh the benefits of whatever therapeutic interventions we would provide. And then also, will compelling the inpatient stay result in a loss of trust and cause avoidance of healthcare institutions going forward? And I think this is a very serious concern for a patient like Mr. Lewis, who may not come back, and then we risk not just morbidity, but mortality, possibly in the short term. So I'm gonna skip over this part so we can have some discussion, but I wanted to get to what sometimes happens in these cases is that as this disposition plan goes forward, there comes tensions, and a patient, like in Mr. Lewis's case, becomes more aggressive as he feels his safety threatened, and then we have an unsafe environment in the inpatient setting, and it's unsafe for all involved, and that becomes really, really difficult to in another place or another context in which to think about power to define the narrative of what's safe or unsafe at an individual, interpersonal, and institutional level. So I'll skip that for now and just summarize with how to think about different things, different standard medical ethical terminology we use in these settings, especially ethical principles that really matter to complex dispositions, and how to make sure we're bringing in justice that's not just about like a utilitarian distributive justice, but also social distributive justice, where we're thinking about health disparities and inequities. So thinking about recognizing barriers, incorporating equity and social determinants of health, and how we think about a baseline of medical safety, autonomous and non-autonomous preferences, as well as self-determination and bodily agency when we're talking about respectfulness, harm minimization. We just have to make sure we're not only incorporating different perspectives, which we always try to do, but also thinking about what are the least restrictive means. And we've talked about these other ones as well: fair distribution, responsibilities, and transparency. I think the biggest issue here is this fair distribution is, what can the hospital do? What is within the hospital's realm of power, right? You can't fix housing for Mr. Lewis, but that doesn't mean there are things we can do creatively to work with Mr. Lewis to not only try to find housing for him while he intersects with us, but also in what ways can we combat the ways in which societal injustices are impinging on Mr. Lewis, such as trying to change his narrative in the chart, trying to find more skilled nursing facilities who would be accepting of him, and so on. I'm going to end there with some practical considerations for both general thinking about complex disposition, but also then specific cases of declining disposition and specific cases of medically unsafe disposition. In all of these, there are practical ways to attend to this, including things like having a multidisciplinary meeting, team, or service. So I sit on a weekly discharge consult service meeting at the University of Washington, where we discuss cases like Mr. Lewis and strategize together about how to meet his goals, understand safety and find a safe pathway, a safe enough pathway forward for him. Likewise, having teams that can de-escalate when tensions might mount because of safety being threatened for a patient, even just in the discharge planning, that can be the experience for the patient that they're being threatened to be forced into an unsafe environment, like discharge to the tent for Mr. Lewis. So yeah, with all that, I think it's really complicated, and we're trying to together kind of figure out how, or my collaborators and I are trying to together figure out how exactly to not only bring into the ethical analysis, but into the charting. How do we think about power and injustice, oppression in these kinds of cases? And what does it change about our recommendations and how we might proceed so that we're treating like cases alike and not just treating everybody the same, which doesn't make sense, especially when safety is different for different folks. So I'll end there. I'm seeing that some fantastic chat that I'm going to start to look through, but any questions?
I can read a few of those if you'd like, Gina.
I'm just scrolling up to where, let's see. So there, it looks like there's some chat about a potential threshold. So, oh, thanks for some. So let's say a threshold, however defined, is reached, but that is a decisionally capable patient's choice when engaging with them where they are, despite limited options, still mitigate risk harm versus the rest being bad rather than thinking about degree of risk harm on a spectrum. Yeah, I completely agree. I think not only should we think about the degree, and thinking about risk and harm is different. So that we want to think about what are the harms and how substantial are those harms, and then what is the risk of those harms happening. And so thinking about those two things separately, and then also, yeah, not just on a spectrum in terms of both, like the level of harm might be different and the level of risk might be different for each of the potential harms, but also the way in which the same thing might be differently harmful to a different person, right? So discharge to that skilled nursing facility is particularly harmful to Mr. Lewis because of these previous experiences of discrimination and the re-traumatization that might happen by going through them again. And so I think then negotiating the different kinds of harms that, like, if I was in the same position and they were determining whether to discharge me to that skilled nursing facility, I might not face that same discrimination. So that harm is different for me, and it may not be unsafe in the same way. And then, James, can you comment again on the balance of the patient in front of us and the wired stewardship of hospital beds? Yeah. So, and I think this point is really important because I think sometimes people separate, right? We're thinking not just about what justice and equity look like for Mr. Lewis, but all the patients, right? So if they're, and this is really dependent, right? Is it true that there is a capacity problem in the hospital? If not, is it really a stewardship problem? If it is, then we're going to have to balance, right, that access, not just in general to anybody, but especially if you think about particular locations, for instance, a rural location, you might be considering that acute care for Mr. Lewis, who no longer needs acute care and faces, a number of societal inequities and forms of disempowerment. But a lot of your other patients experience that too. And so you still might, and this is where policies can help to kind of define what's a reason, not just what's a reasonable time frame to allow for a broader search, for instance, but also under what circumstances exactly is it reasonable to delay discharge, and define those kinds of categories and say, well, we don't yet have a sufficiently medically safe discharge, and that's why we're delaying discharge, versus the patient doesn't want to go to that skilled nursing facility because they didn't like the way it looked on the website or something like that, right? That's a different reason for delaying discharge than it being medically unsafe because the patient has previously experienced discrimination at that institution. Any other thoughts about that? I think this is a really, I mean, it's a really difficult piece of this because you have to find that balance of least harm, right? And greatest good for the greatest number, but also factoring in not treating everybody the same in some utilitarian senses, right? But factoring in the different kinds of harm and different kinds of disrespectfulness that go in line with justice as equity. And so thinking about healthcare disparities as part of the negotiation of, we can't do what's right by everybody. We just can't, like, our society is impossible to do that. And so we have to find out, how do we negotiate? What are the principles we're following? What are the reasons why we might delay a discharge or compel a patient to stay? And in those reasons, factoring in justice as equity, at every stage.
I think we may be coming up on the end here. Let me take this opportunity to thank you for a wonderfully engaging and challenging talk, and thank the audience for wonderful participation today. It's really nice to be challenged to think about how the kind of concepts and tools that we are so familiar with in this space may need to be rethought in light of kind of justice and empowerment and disempowerment lens. So thank you. And I want to remind everyone that the next talk in this series is on January 12th. LaTanya Trotter will be joining us from the University of Washington. So on that, thank you so much, Dr. Campelia. This was wonderful.
Thanks so much, everybody. Thanks for the great discussion. Dave, is there any way I can get this chat so I can